Hello, everyone, and welcome to today's session. We have one more minute, so we'll see if we get a few more folks, and then we'll kick off right at the top of the hour. All right. So thank you for coming. We're so glad you were able to carve out the time to join us today to talk about this super important topic. We have a packed agenda today, so we are going to dive right in. If we can go to the next slide. We will not be able to live answer Q&A today, but we encourage you to please do use the Q&A feature to enter in any questions you have, and we will work to incorporate responses into future sessions or into some of our written materials that we're developing through this work. So please do go ahead and ask the questions, and we'll do our best to answer after today. So today kicks off this community of practice on our next slide here, dedicated to redeterminations as impacted by HR1. Today's session is focused on building the policy foundation to prevent disenrollment, and subsequent sessions will build on this foundation with more of an operational focus. Next month, we'll focus on identifying individuals who are at risk for disenrollment and intervening to help them maintain continuity of coverage. In September, we will discuss rapid re-engagement and recovery processes for those who do in fact lose coverage. And then in October, we'll pull it all together, talking through strategies to measure and monitor the impact of these changes across your organizations through more of a continuous quality improvement lens. Next slide. We also want to make sure that folks are aware of an additional opportunity to engage as part of the practice transformation cohort. So this is a separate track within this community of practice that will provide organizations with some additional resources. This cohort will have access to an additional 30 minutes of session content, during which we'll introduce practical tools that organizations can use to really take this content and apply it to their organizations. Things like process maps, client FAQs, and a tracking and monitoring tool. This cohort will also have access to office hours that are not available to the general audience. So space is limited. This is a competitive application. Application criteria is described further on the form that we have here linked in the slide, and applications are due next Monday, July 20th. Next slide. Big picture, the focus of the National Council is to advocate for policies that ensure access to high quality services that build the capacity of organizations and promote a greater understanding of mental well-being as a core component of health. The changes that are coming as a result of HR1 make this work even more critical, and we're grateful to have the opportunity to provide this community of practice as one piece of trying to support all of you to make sure that we make this process as seamless as we can. At the end of today's session, we're going to introduce you to some more of what the National Council is doing to work on this, and so please stick around all the way to the end to make sure that you get that content. Next slide. Here we have the presenters for today's session. My name is Katie Lipp, and I'm a principal with Bowling Business Strategies. We have partnered with the National Council to develop and facilitate this community of practice. BBS, Bowling Business Strategies, is a national behavioral health and consulting firm that is based in Philly. And we really specialize in helping behavioral health organizations translate policy and payment changes into actionable strategies, whether that means launching new services, redesigning workflows, or otherwise positioning the organization for long-term viability. I am joined by Dr. Alyssa Schatz, Health Policy Consultant, and Peter Delia from the National Council. And you can read more about each of us via the link in the chat. So today's presentation has a bit of a different flavor than the rest of our planned sessions. If we go to the next slide, we can look at today's learning objectives. It will include an immense amount of complex policy information. We'll summarize changes to redetermination and discuss state-specific implementation options paired with implications for practice. It may feel overwhelming. It will likely feel overwhelming, but it's really intended to provide the scaffolding that we'll all need to inform future sessions and next steps. So take in what you can, and we'll continue to build on this in future sessions. So with that, I'll hand it over to Alyssa to get us started. Thanks, Alyssa.
Thanks so much, Katie. Hi, everyone. It's so great to be here with you today. And I just want to start by reiterating what Katie just said. Today is going to have a lot of complex policy information, but it's all relevant to your efforts to retain health coverage for the people you serve. And it's really a foundation for the future work that you're going to be doing here. There are going to be lots of opportunities to apply what you learned today in future sessions. So I'm going to begin by giving a quick overview of HR1, which is also known as the One Big Beautiful Bill, or the Working Families Tax Cut legislation. And I'm going to discuss how it relates to the deep dive topics that we'll be going into today. So HR1 was an enormous bill with many different implications for both the Medicaid program and also the ACA exchange subsidies and tax credits. And those provisions were really trade-offs that Congress made to partially offset tax cuts. Those trade-offs are projected to result in millions of people losing coverage, although I should say that estimates do vary. And you can see here that the CBO estimates coverage losses of 10 million. So this is not insignificant. And I also think it's important context to understand that we've had previous instances of policies like Medicaid unwinding that have shown us that frequently when people lose coverage, in the example of unwinding, we saw that more than two-thirds of people who lost their coverage lost it due to procedural issues. And so it's reasonable to expect that some of that may have been due not to ineligibility, but to paperwork issues. And that's important here. It tells us that implementation of these policies and how we act now will have a huge impact on the actual outcome of these policy changes. So because Medicaid is a state-federal partnership, the implementation of these changes will be guided by both federal and state regulation and policy. And so as behavioral health leaders, you have the potential to play a huge role at the state level in protecting enrollment and coverage and minimizing inappropriate disenrollments as this moves forward. I recognize that that means more administrative burden and time for you. And so I'm really grateful to BBS and the National Council for creating this space and these workflows and the community of practice that will enable you to be a part of protecting coverage for the people that you serve. Next slide, please. So HR1 made some significant changes to the way that the Medicaid program is structured. TANF has had work requirements since 1996. SNAP has had some version of work requirements actually since the 70s. But historically, Medicaid did not have these community engagement or work requirements. And I think that's partially because it was historically limited to certain populations, like low-income people with kids, low-income individuals with disabilities. But the ACA expanded Medicaid, which dramatically increased access and eligibility, which is wonderful. But following that, we did see renewed calls from members of Congress to consider community engagement requirements and work requirements specifically for that expansion population. HR1 did finalize those proposals and those calls, and so that brings us to today. So today, the two items from HR1 that we're going to do a deep dive on include number one, the increased Medicaid redetermination frequency, specifically for the expansion population, for whom the cycle will now be every 6 months instead of every 12 months for the traditional Medicaid population. States must also implement community engagement requirements by January 1, 2027. And so that's the second thing that we'll be discussing today. There are exceptions to this. There are a handful of states that are choosing to implement earlier, and states can also request a good faith effort waiver, but I should note that that's extremely limited. We'll talk about that later. We should not anticipate that your state will get one of those waivers because they're anticipated to be so very limited. Also important to note that in the statute, states have the option of doing a 1 to 3 month look back period for community engagement requirements, which means that states have to look back for at least 1 month and not more than 3 months, according to the statute. I also think it's worth noting that HR1 does many other things that may impact the people that you serve, including restricting Medicaid eligibility and ACA exchange tax credit eligibility for certain immigrants. And it also restricts the Medicaid retroactive coverage period from its current 3 months being allowable down to just 2 months for non-expansion populations or traditional Medicaid coverage, and just 1 month for expansion enrollees. So that does have the potential to have an impact on you and the people you serve. But again, today we are going to be focusing in mostly on the redetermination cycle and also the community engagement requirements and those verification processes. Next slide, please. So let's begin by taking a deep dive into HR1's changes to Medicaid redetermination, along with a review of the CMS guidance that was recently given in March to states about these redetermination changes. Next slide, please. So beginning on January 1, 2027, Medicaid expansion states are required to implement 6-month redetermination processes for all expansion adults, meaning any expansion population adults age 19 to 64 in an expansion state or a state that provides minimum essential coverage through an 1115 demonstration. However, functionally today, this means just full expansion states. There are also a number of exempt populations, including certain American Indians and Alaska Natives, individuals enrolled in other Magi-based groups like pregnant women, dependent children, or individuals enrolled in non-Magi groups like disabled individuals with Medicare, for example. Also worth noting that redetermination does not enjoy that these changes to 6 months does not enjoy the same exceptions as the community engagement requirements. So later today, we're going to talk a lot about exceptions and excluded individuals for the community engagement requirements in Medicaid. That is distinct from these 6-month redetermination periods. So someone may have an exception or be excluded from community engagement requirements, but still have the every 6-month redetermination period. Next slide, please. So in terms of what this means for you, the most important action for behavioral health professionals today is to identify any individuals you serve who may be covered under the Medicaid expansion category rather than traditional Medicaid. We're going to get into exceptions for community engagement requirements later, but again, a really important distinction for the people that you serve to understand is that even if they have an exception from the community engagement requirements, they are likely still subject, if they're in the expansion population, to these 6-month redetermination frequency periods. Next slide, please. So these are the states that are required to move their expansion adult population to 6-month redeterminations beginning January 1 of 2027. And as you can see here, Georgia and Wisconsin are not included. They do have some expansion adults in those states. The way the statute is written, because they have only a partial Medicaid expansion, they are not subject to the 6-month redetermination period. Those expansion individuals in the state, though, will be subject to those community engagement verifications, which could mean more frequent paperwork. Next slide, please. So for expansion states, this slide shows you the stepwise process that states must use when initiating redeterminations. States must first attempt an ex parte renewal process, meaning that they must use existing information sources that they have at their disposal, which could include things like Social Security information from other benefit applications, before they reach out to the beneficiary to request information for the renewal. If they are able to determine eligibility using this ex parte process, then the individual should receive a notification that they've been re-enrolled and all should be well. However, if they are not able to determine eligibility using ex parte, then the individual should receive a notification from the state. They must notify the individual that they need additional information with enough time to complete the pre-populated form by the end of the eligibility period. Individuals must be given at least 30 days to complete and return the pre-populated form and any other requested information. States must also consider eligibility on all bases. So just because you may not be eligible for one, they have to consider other bases um, before they can determine that someone may be ineligible. If the state finds that someone is ineligible across all categories of eligibility, then they can send a notice of ineligibility, and that will initiate a 10-day advance notice and notification of fair hearing rights. It's also important to note here that states cannot shorten or extend eligibility to align different members in a household's redetermination timeline. However, it is possible. So, to give an example, perhaps one spouse is up for renewal in March and another, their eligibility period is up in June. It is possible that the state will go to initiate the renewal with the individual, the spouse in March, and learn of something that has implication for the other household members' eligibility, like an income change. Although they cannot change those periods to be shorter or longer to align the household members, if they become aware of something like an income change that could impact the other person's eligibility, then they are required to take action on that as soon as they become aware. So next slide, please. So what does this all mean for you? The most important thing right now, first and foremost, is to confirm that the people that you serve have up-to-date contact information with either your county assistance office, your Department of Social Services, depending upon what that entity is called in your state. Making sure that they have the correct contact information is really essential right now because these notifications are imminent. The second thing to do is to work with the individuals you serve to monitor for communications and then to take action swiftly if or when you receive requests for additional information. It's also important to document and track this information as best as you can. Next slide, please. So states have two options for how they can implement these redeterminations. Um, So another action item for behavioral health providers right now is to ask your state which option they are choosing for redetermination, since they can select from these two options. And that will help you to understand how those state processes are going to impact the people that you serve as we move into 2027 and these changes are made. Option 1 allows states to move an individual's previously scheduled 2027 renewal that was set with a 12-month period because it was scheduled in 2026. It allows that state to move it to an earlier date in 2027. States are not allowed to do this in a way that would reduce people's enrollment to less than 6 months. But if someone would already be at or beyond 6 months of enrollment, then the state may initiate earlier in 2027. CMS, I think, rightfully acknowledges that states that are electing this option are likely to have a higher level of administrative burden and the potential for some log jams when they do this, because there's going to be a much higher volume of applications at earlier points in the year if they do this. Option 2 allows states to simply use the existing renewal rate for that individual that was scheduled in 2026. And then once they go through their first previously scheduled renewal in 2027, then they will move to the 6-month period. Next slide, please. So I know this is a little bit confusing to wrap your head around what the different options look like in practice. So we're going to go through some of these scenarios that are pulled directly from CMS guidance to states. So this slide has several examples from states that select option 1, which is that option that I was talking about, where people move to an earlier renewal date in 2027 rather than keeping their previously scheduled renewal date. So example 1 is Jill. Jill is enrolled in the adult expansion group as of May 1, 2026, and has an eligibility period through April 30th, 2027, because again, she has this renewal date was set in 2026, so it was a 12-month period at that time running through April 30th, 2027. The state that Jill lives in has selected option one to immediately move eligible expansion adults as soon as 2027 hits on January 1. Because Jill will have had more than 6 months of eligibility on January 1, the state will initiate her redetermination the first business day of that year, which is January 4th, 2027. From this point on, pending eligibility, Jill will receive 6 months of eligibility for every period moving forward. In example 2, we have Max, who is also enrolled in the adult expansion group, but his eligibility period began later. It began November 1, 2026. And so that original period of 12-month eligibility would have ended on October 31st, 2027. But his state also selected option one. And so they immediately move, or because Max has not had 6 months of eligibility on January 1, 2027, the state then adjusts his eligibility period to end on April 30th, 2027, which would be his 6 months instead of his originally scheduled 12 months. The renewal is initiated on March 1st, 2027, in order to be complete by April 30th, 2027, because it takes the state about 60 days to complete this. So they'll initiate it 60 days earlier in order to be done by the time the eligibility is complete, April 30th, 2027. And then in example 3, we have James, whose original eligibility period is September 1st, 2026 to August 31st, 2027, which would have been 12 months of coverage. But again, his state chose to move that renewal earlier. So his eligibility period will now end on February 28th, 2027 instead. It also takes a state about 2 months, about 60 days to complete the renewal. And so the renewal will be initiated January 4th, 2027, in order to be completed by the time that his eligibility is up, February 28th, 2027. Next slide, please. And so on this slide, we are showing an example from a state that selects option two. This is much more straightforward, as you can imagine, because if states who are selecting option two are keeping the previously scheduled renewal date, this means that whenever the individual in 2026 was scheduled to have their renewal in 2027, that will remain. And then following that first 2027 renewal, at that point, the individual will shift to a 6-month period. So here we have Jane. Jane's eligibility period began August 1st, 2026 and goes through July 31st, 2027. Jane's state elected option two to retain the previously scheduled renewal dates. So she becomes subject to community engagement requirements on January 1. That does not shift. Her requirements are still there on January 1. And they are electing to verify 1 month of community engagement at renewal. Their renewal process takes about 90 days. So Jane's renewal is initiated in May of 2027, about 90 days before August 1, 2026. Her eligibility is renewed for August 1st. She's found to be eligible. And then her next renewal will be 6 months later on January 31st, 2028. So again, these come directly from CMS. I hope that they are helpful in sort of wrapping your head around what this may look like for the people that you're serving, depending on the option that your state chooses. Next slide, please. So for the remainder of this session, we're going to take a deep dive into the community engagement requirements outlined in HR1, as well as some of the detail that we've gotten now from CMS in the interim final rule with comment period. I will note that it is interim, so these things can change. Some provisions, those that are not outlined specifically in the statute, can change, but we should proceed as though it will be finalized while also monitoring for changes. Next slide, please. So beginning on January 1, 2027, or earlier at state's option, all eligible Medicaid expansion adults are subject to community engagement requirements in order to retain their eligibility. So as you can see, this is another population that is specifically impacting the expansion population. But there are also specified excluded individuals. and there are mandatory exceptions. And at the option of the state, there are also short-term hardship exceptions. So this is a difference from the redetermination. These are exceptions that are specific to the community engagement requirements. If an individual meets any of these exceptions or excluded individual status, then they are accepted from proving that they have met the community engagement requirements for that period. So we'll review these different exception categories today. States are able to consider many different sources of evidence or data to show that someone has met an exception. And at the state's option, they may also allow self-attestation for certain exceptions through 2027. But in 2028, it shifts to only being allowable once per continuous enrollment period. For individuals not falling underneath any exception, they must meet 80 hours of community engagement activities or lose coverage. States, as I mentioned earlier, also have to implement a look-back period of between 1 and 3 months, and that's at the state's option of choosing. Next slide, please. So these are states that have expansion population beneficiaries that are subject to community engagement requirements. As I mentioned in the last section, noticed here that while Georgia and Wisconsin are not subject to the 6-month redetermination, they are subject here for their expansion population adults to community engagement requirements. I also think it's worth briefly noting that this is applicable to US states, not to US territories, just in case there's anyone here to whom that may apply. US territories are not subject even if they have an adult expansion population. Next slide, please. So there are 4 big groups that I want to drive home for you today to understand related to community engagement requirements. There are sort of 4 distinct groups of individuals. The first group are specified excluded individuals, and there are 9 categories of specified excluded individuals. In other words, they are not applicable individuals for the purposes of community engagement. The second group is that there are also applicable individuals for whom the requirements technically apply, but they meet a mandatory exception. The third group is applicable individuals, but they have, if the state has selected to allow this, a short-term hardship exemption. And we are going to review in detail each of these. Finally, group 4 is not listed here, but group 4 is individuals who meet none of these exceptions. They are not excluded individuals, and they do not meet any of these exceptions, whether they're mandatory or short-term, and they are subject to community engagement requirements. So we're going to begin today by reviewing the specified excluded individuals. And then we're going to dive into the medical frailty category, which is one of those specified excluded individuals. And there's some complexity there that we'll dive into. And then we'll review the exceptions for applicable individuals, both mandatory and short-term, followed by reviewing the ways that people can meet community engagement requirements if they are not excluded or accepted. So to start, specified excluded individuals include former foster care youth under age 26, American Indians and Alaska Natives, guardians of a child under 13 or a disabled individual, veterans with a total disability rating, medically frail individuals, which we'll go into depth on in a minute, people who are already meeting work requirements for TANF or SNAP, participants in a nonprofit or public drug or alcohol treatment program. And it's important to note here, I said nonprofit or public because for-profit programs are not included. Also worth noting here that states may establish a minimum time requirement at their option. Inmates of a public institution, and also people who are pregnant or covered in postpartum Medicaid coverage. So as you can see, there may be people who have overlapping categories here, but once a state identifies one exception for that eligibility period, that's all that is required to confirm that they are accepted from these requirements. It's also worth noting that for some of these requirements, it's a one-time verification per continuous enrollment period, specifically American Indians and Alaska Natives, since that is not something that is dynamic or will change. CMS has provided additional detail on the definitions of each of these in their guidance and their interim final rule, and that can be found in the appendix of the slides for your reference following this presentation. Next, we're going to review the detail associated with the medical frailty specified excluded criteria. So next slide, please. I also should note, you're going to be going into this all in more depth in session 2. So if you have questions or there are things you want to dig into further, don't worry, there will be an opportunity to do that. So as you just saw, one category of a specified excluded individual is an individual that is medically frail or otherwise has special medical needs, preventing compliance with community engagement requirements. There are 5 qualifying categories that, again, have definitions that can be found in the appendix. The categories are blindness or disability. Substance use disorder is specifically called out, and it should be noted that this is specific to individuals who have less than 5 years of recovery. People with disabling mental disorders, that is the language that is used in the legislation. People with physical or intellectual disabilities, and people with serious or complex medical conditions. And for each of these criteria, CMS has specified that simply having a diagnosis is not enough to confirm they meet the exception. So that is an important take-home message for all of you today. CMS has indicated that individuals must be able to demonstrate that this functionally impairs their ability to meet community engagement requirements. Unfortunately, the interim final rule is limited on detail about exactly what paperwork or assessments should be used to do that. So, there may potentially be future guidance coming, but for now, there's a less specificity on that. Next slide, please. So CMS does not fully define these categories and defers to states to some extent. But they do encourage states to use established diagnostic frameworks like the DSM-5 or the ICD-10. And they do also name some specific disorders, which you can see here. So, for example, underneath disabling mental disorder, they have specifically named schizophrenia, moderate or severe bipolar disorder. Underneath substance use disorder, they've named alcohol use disorder, opioid use disorder. It's also important to note for substance use disorder that this is not conditioned on active treatment. And as I mentioned, again, just to drive it home, it is specifically for people who have under 5 years of recovery. In every case, the condition must substantially limit the individual's ability to meet the community engagement requirement. Next slide, please. So as I'm sure that everyone on this call is aware, you must comply with federal confidentiality protections for substance use disorder treatment records under 42 CFR Part 2. Those requirements, it's important to know and remember, still apply here. So verifying an exemption should never disclose protected Part 2 records without proper consent, which means that as you build workflows for these processes, you should build consent and record handling steps into those workflows. Next slide, please. So this is survey data here that I think is of interest. It was collected by KFF, formerly known as the Kaiser Family Foundation. It's from March, so it's a little bit out of date, but I think still applicable and interesting. It shows the data sources that states plan to use to inform their medical frailty exceptions. And you can use common sources that they're planning to rely on in their reviews, include things like claims data, confirmation from a treating provider, and also self-attestation. And this data was collected before we knew whether self-attestation would be allowed. We now know that it is. And at that time, 4 states planned not to allow self-attestation. 30 planned to allow self-attestation, and 9 had not yet decided. Next slide, please. So we've reviewed now specified excluded individuals, and we're going to move into people who are considered applicable individuals, but have mandatory exceptions on this slide. So as you can see, the mandatory exceptions are outlined in the statute and are not optional for states. And they include people under the age of 19, people who are enrolled in or entitled to benefits in Medicare Part A, enrolled in Medicare Part B, are in a mandatory categorically needy group, and also individuals who have been an inmate in a public institution, meaning like in prison, in the last 3 months before being subject to community engagement requirements. CMS also notes that states may choose to allow short-term hardship exceptions, so we're going to review those on the next slide. Um, so it was originally thought that states may choose to cover some of these short-term hardship exceptions that you see listed here. CMS has interestingly in the guidance clarified that this is all or nothing. So if states are going to cover or allow any of these short-term hardship exceptions, then they have to allow all of them according to the most recent interim final rule. These short-term hardship exceptions include someone who has received an inpatient hospitalization stay, nursing facility, intermediate care facility for individuals with intellectual disabilities, inpatient psychiatric hospital services, or other services of similar acuity. Individuals who reside in a county that has had an emergency or a natural disaster that's been declared, individuals who reside in a county with high unemployment, that is 8% or that is above 8% or 1.5 times the national unemployment rate, and also individuals that must travel outside of their community for medical services that are not available there in their community in order to treat a serious or complex medical condition. And important to note here, that's for individuals themselves doing that, but also for caregivers who may be either accompanying or supporting in some way the individual needing to travel for that care. It's also important to note here that these need to be applied for. So you should not, unlike the mandatory exceptions where in ex parte, they're going to be automatically reviewing for that. That's not going to be the case here. You need to apply for short-term hardship exceptions, even if the state has allowed it. Next slide, please. So I'm going to provide a little additional detail on two of these hardship exceptions that I think are of relevance to this audience. So for those who have had an inpatient hospitalization, they may also be served in other services of similar acuity. And that could mean another institutional level of care that's not outlined specifically there. Like, for example, a VA hospital is used as an example. Or it could mean a non-inpatient or non-institutional level of care that is provided to someone. It could even be in an outpatient or home-based setting. But if it's in that instance, then you have to be able to demonstrate that it is for a condition of a similar level of acuity and that the individual would otherwise be served in one of those settings. You also have an opportunity to show that there's good evidence that if the individual did not receive this other setting of care, that they would then wind up in a hospital or an institutional level of care. In terms of the travel exception, one sort of granularity here to understand is that CMS has noted that if it's a caregiver who is applying for this exception due to a dependent traveling for care, they may qualify by traveling with the dependent. They also may be able to qualify if they are not traveling with the dependent, but that they are supporting the logistics of that in such a way that it makes them unable to meet the community engagement requirement. But again, they'll have to be able to demonstrate in some way that this prevented them from being able to reasonably meet that requirement. Next slide, please. So this slide gives you some interesting data from states on their plans for their short-term hardship exceptions. This was back when states thought that they would be able to pick and choose, so it's a little bit out of date. But as of March, at that time, 26 states plan to offer all short-term hardship exceptions, 2 plan to offer none, and 3 plan to offer just some, and 12 states were still in the process of determining that. Next slide, please. So this slide provides a high-level overview of what the state workflow must look like according to CMS. And CMS notes that states must first determine whether someone is a specified excluded individual, one of those 9 categories that we discussed, including being medically frail or in a treatment program for substance use disorder, for example. And if at that time they're found to be excluded, then the state must not evaluate exceptions or whether they have qualifying activities toward the requirement. And they must stop, looking for any other criteria. If a state determines that they are not excluded and they are an applicable individual, then they must evaluate any mandatory exceptions. Again, short-term hardships exceptions not included here because you have to apply for those, but they must evaluate those mandatory exceptions. If the state has done both of those things and then determines that the individual is applicable and not accepted, then they will evaluate whether the individual met the community engagement requirements. Next slide, please. So for applicable individuals that have not been found to be accepted, from the requirements. They must demonstrate compliance by providing evidence that they have met at least one of the following criteria: that they have worked at least 80 hours in a month, and that can be paid self-employment, unpaid work, in-kind work, or that they have completed at least 80 hours a month of community service, and there are tracking requirements for that and reporting requirements, or that they are enrolled at least half-time in a qualifying education or training program, and CMS leaves it up to the states for the education or training program to define half-time. But it can be trade schools, colleges, universities, high school, GED programs. And then number 4 is interesting. It also can be any combination of those 3 adding up to the 80 hours. So you could have, 20 hours of work, 20 hours of community service, and then education credits that with the calculation would equate to 40 hours. CMS also allows or considers it to be met if you have a monthly income that is not less than the applicable minimum wage multiplied by 80 hours, which is $580 a month, or if you're a seasonal worker, if your past 6 months of income averages out to $580 a month or more. Next slide, please. States are required to conduct initial outreach to members from June 30th to August 31st. So that's right now. We are in the period in which states should be sending out these beneficiary outreach and notices. So now is the time to be monitoring for initial communications. States must also send a notice on a periodic basis thereafter, is the language that they use, when certain events occur. So that can be for determination or redetermination of eligibility at application, at renewal, upon a change in circumstances like an income change or another event, when the state elects or deselects short-term hardship exceptions, or upon the loss of specified excluded individual status. CMS also requires states to include information on their public website. And because exceptions can change and are dynamic, CMS is requiring states to send these notifications to all potential impacted adults. So that's important to know because some people may get these notifications and might be confused about what it means. So it's important to help people understand exactly what that means. CMS is also encouraging partnerships to disseminate this information. So this also might be a good opportunity for you to work with your local county assistance office or Department of Social Services to help spread the word and raise awareness among the populations you serve. Next slide, please. And so these outreach and notice requirements for states are required to include certain information, including how to comply with and demonstrate community engagement, including an explanation of the exceptions, who's applicable, the number of months that you must demonstrate compliance, and how frequently that verification will happen. So again, that's going to be state specific, so that will also be important to look for. It also must include the consequences of non-compliance, including loss of coverage. Non-compliance results in loss of coverage on Medicaid, but also on the ACA exchange for those APTC/PTC, those credits. Next slide, please. And in terms of the notice of non-compliance, so if a state is unable to verify compliance, an exception, or an exclusion using available reliable data, it then must send a notice of non-compliance. And at that point, the individual has 30 calendar days of notice where they can make a satisfactory showing. If they do not, in that 30 days, provide information that makes a satisfactory showing, then the state must deny the application or disenroll them. And that has to happen by the end of the month that follows the month in which that 30-day period ends. States can do this in two ways. One is through concurrent notice, where the individual will receive a notice of non-compliance at the same time that they get that pre-populated information that we talked about, where they're requesting information that couldn't be verified during ex parte. So that will be a shorter period of time because they'll be getting non-compliance at the same time, initiating that period. The other option is for a state to use sequential notice, where the individual will first receive their pre-populated form requesting additional information. And if that information is insufficient, they'll then receive a notice of noncompliance with that 30 calendar day period to respond. So giving a little bit of additional time. Also important to note that some states provide MAGI beneficiaries with more than 30 days to respond to a renewal form. And in terms of, action items for you, again, trying to minimize confusion, helping people understand what they mean. And in order for you to do that, finding out whether your state is using concurrent notice or sequential notice will be important. And of course, it's always important to remember that people are still entitled to their fair hearing rights. Next slide, please. So just like the other notices, there's required information has to be included in notice of noncompliance, including how to make a satisfactory showing. And within that, how to make a satisfactory showing that the requirement does not apply to the individual, which may be the case for many of the people you serve, due to being a specified excluded individual. Also has to include the deadline for providing the information, a description of the consequences for noncompliance, how to reapply if denied. Important to note here, there are not blackout periods or waiting periods, so you can reapply right away. And if they've selected short-term hardship exceptions, information about those short-term hardships. Next slide, please. Okay, so now we are going to go into further depth on some of the state-specific implementation considerations. Next slide, please. So states are allowed to verify community engagement requirements more frequently than every 6 months. As of April 2026, 2 states had confirmed that they plan to verify quarterly, 34 plan to verify only at renewal, and 7 had not decided. Next slide, please. So states may also apply for a good faith waiver, but as I mentioned earlier, this is anticipated to be a very small number of states. CMS has projected probably just 2 states receiving this waiver. So basically, I would not count on your state getting this waiver. In addition, they have many rigorous reporting requirements and milestones that have to be met. So this is not something that you should be counting on, in my opinion. It also only is approved for 6 months at a time, and the longest it can go is through the end of 2028. Next slide, please. So as mentioned earlier, through 2027, states have the option to allow self-attestation for medical frailty. Once we're in 2028, they can only allow it once per continuous enrollment period. And also important to note that several states have already taken action to prohibit any use of self-attestation. So if you're in Utah, Indiana, North Carolina, there's already been action taken to prohibit self-attestation. Next slide, please. So as you can imagine, this poses many challenges for states, including, IT infrastructure around this. There's significant administrative burden for county assistance offices. There is, significant staff capacity issues. It's worth noting that CMS does have money available to support implementation, but recent survey data from Kaiser indicated that many states were not planning to boost staff capacity in any way. 14 reported that, 14 reported that they planned to boost staff capacity, 9 reported no plans to boost staff capacity, and 20 were to be determined. So this could cause significant administrative challenges. And of course, it also creates administrative challenges for you all and for the healthcare system as a whole. Next slide, please. So, in terms of what to watch, there is a lawsuit from 25 states, and that is specifically challenging the medical frailty guidance from CMS. We also anticipate there could be additional lawsuits, but again, we should be not counting on the outcomes of lawsuits or anything like that. We should be proceeding as though these things will be finalized. We also should be looking out for potential additional guidance. It's possible CMS may issue additional guidance on medical frailty. It's also possible that states may look to existing work requirement standards and forms that are out there. So again, because it's interim, things can change, but we should proceed for now as though they will be finalized as it is, while also monitoring for additional guidance. Next slide, please. And so these are a list of questions to ask your state. These are the 4 big buckets, but you're going to be getting these in an additional workflow. So I'm not going to go into too much detail on these today. Katie and her team have done a great job of putting together this workflow to support your work. So I'm going to hand it back over to Katie. And thank you all so much for everything that you're doing to support maintaining coverage for the people you serve.
Thank you, Alyssa. And as promised, it was just as jam-packed as we said it would be, right? So we're going to shift gears a little bit in our last 10 minutes or so to introduce you to a framework to sort of pull all of this information together and give you some guidance of what do we do with this policy information. So next slide, please. When I think about the redetermination cycle as it currently exists at many organizations, the client checks in for service, the front desk runs an eligibility check on their insurance, and we identify that their insurance has lapsed, right? That's probably where we're finding it out in many cases. We let the individual know that they need to complete their redetermination, and then we check in with them to see what sort of supports they need and continue to monitor it until their insurance has been reinstated. And then from there, we typically have this retroactive period where we can go back and get that service covered. I fully acknowledge that this process has never been easy, but there have always been points of vulnerability, right? So things like, an individual with really dynamic and changing contact information, or trying to track down proofs, or supporting someone with transportation to get to the Medicaid office. With these changes coming with HR1, all of these barriers get compounded. And so, for all clients with Medicaid, we face this smaller window for retroactive coverage. And with that, the need to be more proactive in tracking redetermination dates. And then for our expanded Medicaid population, there are further risks, as we've talked through today. Next slide. So, we created this model, an adaptation of the sequential intercept model, to offer another way to sort of think through this shift from reactive to proactive, where we've mapped where people fall off the Medicaid rolls and lose access to care, and where targeted action can help keep them in. So each intercept gives teams a discrete decision point to understand the policy, plan a response, and operationalize it. So today, Intercept Zero was all about prevention, helping you all to build your capacity by translating HR1 redetermination changes, and giving us sort of this shared baseline. We didn't get as much into it today, but this foundational understanding is also critical for our care partners that may play a role in fostering understanding across our client population, and also might help might help support our clients to maintain coverage. So schools, community-based organizations. Next session, we'll move into Intercept 1 and get into mapping the affected population, really zeroing in on which client segments face the highest risk of disenrollment, and how you can analyze your workflows to plan a response. We will scope out the resources needed to do this work and consider where there may be opportunities to bill for those activities. And then in the third session, we'll move to intercepts 2, 3, and 4, talking through bridge resources, appeals, and the workflows associated with that rapid re-engagement and re-enrollment processes. And then our final session will sort of pull it all together, establishing a feedback loop to refine the intercepts and associated partnerships and processes, inform policymakers and the public about the impact of these changes, and help your organization understand and plan for what might amount to be long-term implications of these policy changes. Next slide. We've developed a very lightweight scorecard to help you check in with where you are in planning for these changes and where your biggest areas of vulnerability are. So the idea is to look at each of these domains and give your organization a rating based on where you stand today, helping you to kind of think through what needs to happen next. Again, this is super high level at this stage. We'll get into this in subsequent sessions, and we have this as a separate Excel tool to support you in thinking through it. Next slide. So that brings us to the end of our content, but please stick around because we have a number of additional resources and announcements to share with you. First and foremost, please complete the session evaluation so that we can use your feedback to inform our future sessions. Next slide. We also encourage you to join our next session, which we've just previewed a little bit, and the link to do so is here and will also be added to the chat. Next slide. One more little soundbite for our practice transformation cohort. The link is here, and again, those applications are due next Monday. The question was raised in the chat, but just to address it here, we expect to select our cohort by the end of this month. And so with that, I'm going to pass it off to Peter to loop you into some of the other National Council initiatives related to HR1.
All right, Katie, Alyssa, thank you both so much for all of the valuable information you've shared with us here today. I just want to close out briefly by sharing some of what National Council has been engaged in when it comes to both advocacy around HR1 and implementation efforts. So just very briefly, when it comes to advocacy, when HR1 was being drafted and working its way through the legislative process, we worked closely with our members and our allies in Congress to secure some important wins. Among them, we saw CCBHCs, community mental health centers, and opioid treatment programs all included in the bill as facilities eligible to receive funding from the Rural Health Transformation Program. This was critical. Not all facility types were actually named in the statute as eligible to receive funding. So we were very glad to see that. And then, of course, as we heard during the course of the presentation today, some key exclusions and exemptions for behavioral health when it comes to community engagement requirements were also included in the final version of the bill, along with exemptions to cost-sharing requirements for both behavioral health services and specific facilities, including CCBHCs and CMHCs. Under HR1, cost-sharing will be required for some Medicaid enrollees starting October of 2028. We'll have much more to say on that as we get closer to that date. We can go to the next slide. And then also just wanted to highlight the work we are doing in our HR1 Hub. The National Council's HR1 Hub is kind of our central source for all implementation resources. The QR code on the slide right here will take you to the Hub website. And there you'll find all the resources you see highlighted here and a whole lot more. We have our HR1 Journey Map, which is a comprehensive overview of all the Medicaid provisions in HR1, along with a timeline of implementation and some relevant advocacy opportunities. We also have a white paper on work or community engagement requirements, whichever you prefer to call them. It outlines the history of some similar policies and provides some high-level recommendations for clinics and providers on different practices to help patients retain coverage. We also did a survey of our members, measuring a number of different factors that could be impacted by HR1 before most of the bill's Medicaid changes take effect. It measured things like the amount of uncompensated care currently provided, lengths of any wait lists, workforce capacity, and related questions. We'll do that survey again later this year and then into 2027 and 2028 as well, so we can kind of obtain sort of a better understanding of the bill's impacts on our members. We also have some talking points for direct service providers. These are sort of plain language talking points that can be used to explain the coming changes directly to clients. And we've got a number of summaries of the changes coming under the bill, including summaries of the community engagement rule that was discussed today, a new rule on state-directed payments, and changes to non-citizen eligibility, among many others. We've also got a fact sheet and some high-level recommendations for clinics and providers specifically on eligibility redeterminations that nicely complements a lot of the information provided here today. So we really encourage you to check out the hub if you haven't done so already, and keep an eye on it, bookmark the page, and check it out regularly in the months and years ahead, but especially as we get closer to that all-important January 1st, 2027 date. Next slide. And then finally today, just wanted to quickly highlight some of our more general resources. If you aren't already signed up for our weekly policy newsletter, Capital Connector, I really encourage you to sign up for that. It comes out every Friday, and it's a comprehensive recap of everything that happened in federal behavioral health policy in the previous week. It's a great way of staying on top of new policy developments. We've also got our Advocacy Action Center. Here you can check out advocacy campaigns we currently have on a number of different bills, regulatory issues, budget issues. Basically, we provide a pre-written letter to your member of Congress on a given issue that you can tweak accordingly. You just put your info in, we find your members of Congress for you. And so with that, I just want to thank you all so much for joining us today. If you have any questions on anything related to policy, please don't hesitate to reach out to us, email us anytime, and we look forward to seeing you for session 2. Thank you.